Okay. Good afternoon, everyone. Welcome to our third day. The first day was the day of healing for the descendant family members of the United States Public Health Service syphilis study at Tuskegee. And yesterday was our first PHEI day, Public Health Ethics Intensive. This is our 2022 session. This is our 11th year of having these wonderful, engaging presentations. As you can tell from the participant numbers, they're starting to climb as people come on. We had almost 100 people yesterday, and so it was magnificent. My name is Dr. David Augustin Hodge Sr. I'm the Associate Director of the National Center, Director of Education at the National Center for Bioethics in Research and Healthcare at Tuskegee University. Dr. Ruben Warren is the Director of the National Center for Bioethics in Research and Healthcare at Tuskegee University. This discussion today is going to cover two areas. The first area is we're going to reflect on is on HIV and AIDS. The second conversation will be about COVID-19 and ethics. Tomorrow's conversation will be about maternal mortality, where our guest lecturer will be Dr. Neil Shah. And the second lecture tomorrow will be on gun violence. Our guest lecturer will be Dr. Alex Crosby. And the ethicist respondent will be Dr. Riggins Earl. This is a fascinating moment, a fascinating time to be in these kinds of conversations, because what we are aspiring to do is to be forward thinking about what comes next at the National Center for Bioethics in Research and Healthcare. The order is tall. The moment is huge. We are watching, phasing backwards, we're watching unprecedented numbers of gun violence. Now it seems like we've always had that, right? And sometimes the pointing is towards mental health issues. And one of the things that our colleague at Harvard Bioethics Center, Dr. Rebecca Brendel, said in several of the presentations she's been doing on the news, she said that it is less of a mental health issue as much as it is a mental health moment or mental crisis. For example, a person may not have a mental disability of any kind or mental health issue, but if they have a particular mental challenge, like some trauma hit them that moment, that may cause a person to act in such a way if guns are handy to bring out violence. And so that gun violence conversation is necessary because many of the people who are at the end of both ends of the guns happens to look like us. If you look at what's happening in Chicago and has been happening, it has always been daunting to me that during the shooting in Florida, where about 27 students were killed and teachers were killed, in that time between the shooting and the town hall, about 4 times as many people were shot and killed in Chicago alone. And that was very silent. So that's why that conversation is important. Secondly, moving backwards, the maternal mortality conversation is extremely important because in the state of Alabama, where we are hailing from right now, we have an increasing number and high numbers of mothers who are not making it to the end. And it's the Black mothers who are not making it to the end, women of color who are not making it to the end to be there for their babies. And then there's also silent conversation taking place because now you have all of these fathers who are placed in a position to do what mothers have been doing for years, and that is to raise these children and deal with this whole new world. So we're bringing that conversation to bear. Then coming forward, as Dr. Warren mentioned just now, as equipped with Mr. Jesse Milan, is that COVID is not over. COVID is not over. It is still here. COVID-19 is still catching people, still devastating lives, still taking lives. And though the numbers are tremendously reduced for the vaccines and other reasons, it is not over. So caution is necessary, and we have to have that conversation. Now, today's conversation is about something else that is not over, and that's HIV and AIDS. It's not over. And we seem to have kind of dropped our guard quite a bit, and to think that it is not, that HIV is over, and we could, human beings could start behaving or acting or hiding. One of the things I pointed out, as I will talk about when my turn comes, is that in last year, Gilead had requested and appointed us to do a special edition journal on HIV and AIDS. And so they came to Dr. Warren, and we put our journal of healthcare, science, and humanities was the vehicle to put this together. So we came together and we worked very, very hard, and we published this journal. So I will say more about that later. But as we were putting that journal together, it became very, very apparent that the language of pandemic and epidemic are used in very different ways. And we want to try to figure out what that means. So I want to introduce to you now a young man who will be in each of our sessions. We have bioethics honor students who serve as hosts. These hosts will introduce the speakers, and they will field the questions, and they will run the show. Our students yesterday did a tremendous job. I can't say enough about the job they did yesterday. And to our students today, we look forward for them to do an even just as brilliant job. So let me read to you now the bio for Mr. Alonzi Bryant. Alonzi Bryant is a graduate of Princeton Valley High School, where he maintained a 3.7 GPA. During his time at Princeton, he served as section leader and chaplain in the marching band, president of the National Music Honor Society, and was a member of the Math National Honor Society. He is now a freshman computer science major at the Tuskegee University, where he is on a full tuition scholarship, as well as a LSAMP scholarship recipient. He is a member of the Tuskegee ACM chapter and the NSPE Robotics Workshop. Alonzi is a hardworking and dedicated student who plans to use his degree in computer science to advance everyday technology and change the world. Let me tell you something. I love that. The whole notion that he's planning to change the world. And this is what we advocate in the Bioethics Honors Program. Our program has right at 100 students in it right now. And they are amazing, amazing, amazing young people. And among them is Alonzi Bryant. But before I bring Alonzi Bryant on, I would like to ask Dr. Ruben Warren, is there anything that he would like to say before we kick off the session? You're muted, Dr. Warren.
Sure, making it a habit. Nothing other than to say how pleased and proud I am to be a part of this place called Tuskegee University and be engaged in the kinds of issues that have impacted on people in particular for many, many years. And we're really, really excited about the interdisciplinary engagement that we've been participating in over the years. Yesterday was a fantastic session. Today will be even better. And Mr. Milan and of course, Dr. Mack, I can't thank you enough for all that you have done and all that we expect you to do in the future. So Dr. Hodge, let's get it on.
All right, thank you, Dr. Warren. And we go now to Alonzi Bryant. Alonzi Bryant, the floor is yours.
Good afternoon, everyone. I did fail to mention I'm from Birmingham, Alabama. I left that out of my bio. Got to represent though. Our speaker is Mr. Jesse Milan. Mr. Milan is president and CEO of AIDS United, a national organization focused on grant making, policy, and capacity building with the mission of ending AIDS in the U.S. AIDS United has granted over $104 million to local communities during its 30-year history, including over $5 million to 150 current grantees spanning 35 states. A national expert on HIV, Mr. Milan is living with HIV for over 30 years. He is chair emeritus and longtime board officer of the Black AIDS Institute, a senior fellow at Atlas Research and fellow at the Altarum Institute, and Fulbright Senior Specialist in Global HIV. Over the past 3 years, he has worked as the HIV subject matter expert consultant on federal projects, including a CDC study assessing the impact of the National HIV/AIDS strategy and high impact prevention on health departments, and for a federal Department of Health and Human Services study assessing the entire federal investment on HIV and viral hepatitis for the Black MSM population. Mr. Milan travels widely giving keynotes, trainings, and presentations on HIV topics. Without further ado, Mr. Jesse Milan.
Wow, well, thank you, Alonzi, for that wonderful introduction. And thank all of you for this tremendous opportunity. Tuskegee University holds a paramount place in the hearts of so many of us, and your leadership is important not only for what you've done, but for what you continue to do. And the Center on Bioethics and Healthcare is leading the way in a new way to help us understand what is needed for ending so many epidemics and so many pandemics that impact particularly the African American community. I want to thank you, Dr. Hodge, for this opportunity and for your leadership. And I want to thank you, Dr. Warren, for your partnership with us. We had a wonderful session together just a couple of weeks ago at the Congressional Black Caucus Foundation. And it was one about HIV and AIDS, because we need to make sure that our community and our leaders, especially in Congress, are responding to this continuing epidemic. And I want to thank my colleague, Dr. Lachlan Farrow, for connecting me with you, Dr. Hodge, and the Center on Bioethics. Lachlan and I go way back, and I appreciate the intersectionality that he brings to this effort and the continuing leadership that all of you bring as well. I'm going to bring up some slides today because I want to talk about exactly what makes this such an important time for us. And I think that important time really has to do with the concepts that you all have created for the series of colloquiums that you all are planning. The moral issues that impact so many of the issues that you are focused on, COVID-19, violence, maternal and child health, and now, of course, HIV, really have to be addressed in terms of the political environment. And I've couched my presentation today in terms of the political and moral threat that we are facing for ending the HIV epidemic. And I think it's important, especially as we are now just 1 week away from an election, that we understand how the political situation has an impact on our public health situation. And so I will give you some background in terms of the public health epidemiology around HIV/AIDS, but it's important that we think of it also in terms of the political environment. That's not only the electoral environment, but the judicial environment and the legislative environment, because they have a great impact on our efforts to address HIV. And I want to start by giving you just a little bit of background about AIDS United, where I am pleased to serve as the president and CEO. I've been with the organization as president and CEO for 6 years, and Lonzi gave a bio that may be just a little dated, but I've actually now been living with HIV myself for 40 years, and that 40 years spans almost the entirety of the HIV epidemic. And at AIDS United, we are proud to be focused exclusively on ending the HIV epidemic in the United States, but we know that the global pandemic cross-cuts the entire Black diaspora. At AIDS United, we are focused, as you heard, on strategic grant making. Our philanthropic work is one that is renowned. We are one of the top 5 funders for HIV in the United States, one of the top 10 in the world. And through our grants, we have approximately 200 grantees in over 40 states. throughout the country, and they're currently receiving over $9 million from us to support their work at the grassroots level to end the HIV epidemic. There are capacity building. We help organizations who are doing that grassroots work do a better job at achieving their mission for ending the epidemic in their communities. And I'm proud to say that our policy and advocacy team is recognized as the #1 in the country for addressing Congress and the administration on the policies, the programs, and the appropriations we need for ending the HIV epidemic in the United States. And so AIDS United has a strong role for ending the epidemic, and I'm very proud that you've included us today in this effort. Through our work at AIDS United, our policy work is guided by our Public Policy Council, and that council is made up of 58 of the leading HIV clinical service and advocacy organizations in the United States. Some of these are names that I hope you would recognize, like Whitman Walker in Washington, D.C., and GMHC, Gay Men's Health Crisis in New York City. ANAC in the upper right-hand corner, the Association of Nurses in AIDS Care, and in the bottom left corner, IAPAC, the International Association of Providers in AIDS Care. Doctors and nurses have a unique role, but so do advocates. And so the advocate organizations that we represent help lead us to address stigma and discrimination all across this country, especially in the South. And through some of our organizations, they are not only doing clinical work, but advocacy work, like on the far left, My Brother's Keeper in Jackson, Mississippi, which not only is a leading federally qualified health center for addressing HIV in Mississippi, but they also do an annual legislative effort to teach their own legislature how important HIV is. So our Public Policy Council guides us, and that helps, I think, expand the impact that AIDS United has and the role that we play for our community. But I'm going to start with the people. We talked about organizations that AIDS United represents, but our constituents should be understood from all of us, because the HIV populations cross-cut so many different types of people. Certainly, Black gay men, Black cisgender and heterosexual men are impacted by HIV. Black women and Black transgender women are impacted by HIV. We have to talk about the substance abuse community, because they are still 10% of all new transmissions in this country. We have to talk about the incarcerated population, especially as people come out of incarceration who discover that they are HIV positive, and the challenges that they have for re-entering into the community. All of these populations, including in the bottom far left, the aging population. Soon, 50% of all people living with HIV in this country will be 50 years old or older. And before the end of this decade, that number will be closer to 60 to 70% of us who are living with HIV. So we have to be aware that not only our youth, especially those who are 24 and under, who are highly impacted by HIV, but our aging population as well. This picture, I think, gives us a great insight into the variety of communities that continue to be impacted by HIV. So I'm going to make sure that we talk about the epidemiology as well as the moral, legal, social, and judicial issues that are facing us. Let's start with the big picture in the United States. There are 1.2 million people living with HIV in this country, and that number is, of course, expanded globally because there are 37 million people living with HIV worldwide, and the vast majority of them are African American, are people of color. In the United States, we still have new transmissions occurring every year, approximately 35,000 new transmissions. And yes, we still have deaths from AIDS, approximately 12 to 15,000 deaths from people who have HIV each year. But this continuum is one that I think is important for us to understand in order to frame how the HIV epidemic is actually being lived out today. Of the 1.2 million people in this country who have HIV, approximately only 87% know that they have HIV. So about 13% still don't, and that 13% who don't know that they have HIV are largely responsible for all the new infections that are happening in this country. But of those 1.2 million, are all of them in care? No. Not all of them are getting the care that they need. Not all of them are able to stay in care. And certainly the years of the COVID-19 pandemic have not helped people stay connected to their clinical providers, or even to stay connected with their own medications. And so we have to be very aware of this sort of cascade from those who know their status all the way down to the final bar on this viral suppression, because the end goal through all that we have with major biomedical advances in medications is that you would have a virally suppressed status, or that your virus in your body is so low that it is no longer working to replicate itself, to decimate your immune system, so that you would be subject to one of the many AIDS-defining illnesses and then possibly death. So obtaining viral suppression is sort of the gold standard for us living with HIV, and it has a dual benefit. And then the far right column, you see something called U equal U, which means if you have an undetectable viral load, your virus is also untransmittable. So the goal of achieving viral suppression is not only that you might live a long and healthy life and never, ever acquire AIDS or die, but you can't pass the virus on to someone else. Unfortunately, the percentage of people who are not virally suppressed are largely African American, and the percentage of people who don't even know that U equal U is a thing are primarily people of color. So we have a very, very big challenge. Let me continue on. Now, HIV doesn't live in a vacuum. It lives in the intersection of so many of our social issues, as well as so many of our public health issues. HIV certainly lives in the intersection, as you can see at the 9 and the 3 o'clock range, of both racism, structural racism, and homophobia. Those are quite historic with regard to HIV, because we know that historic systemic racism has prevented so many of us from, for a lot of reasons, from knowing our health status around so many different issues, or even having access to care. Look at all the states across the South that have not expanded Medicaid. That may be very much a vestige of systemic racism. Homophobia, definitely, and transphobia, which is growing in this country. Certainly, the poverty and access to care are issues where HIV lives. Those failures to provide access to care, whether it's through Medicaid expansion, or even whether systemic issues within our own communities about whether or not you can actually get to a provider, whether transportation is available, whether jobs are available, whether you have private insurance or not. Those issues are intersecting with HIV, as well as some of the major health issues like sexually transmitted diseases. There are 2 million sexually transmitted diseases occurring in this country every year, and every single one of those transmissions is an opportunity where HIV could be transmitted. Viral hepatitis is an exploding epidemic in this country, and the viral hepatitis epidemic truly intersects with HIV, and so does the opioid epidemic and the injection drug use epidemic, because those are opportunities where with your defenses down because of what you may be taking, or because you're injecting something that may have been shared by someone else, those are opportunities where HIV could be transmitted. And now, of course, COVID, and this year, monkeypox. It is shocking to know that 40% of the people who have been diagnosed with monkeypox also were being diagnosed with HIV. This is not that they were HIV positive and knew it before they had monkeypox. They were diagnosed with monkeypox and HIV at the same time. So the intersectionality issues are one that we continually have to understand in order to fully understand how the HIV epidemic works. Now, I want to move away from this broad epidemiological overview to talk about the political environment in which HIV lives. There is no question that the January 6th insurrection had vestiges of racism right there in the midst of it. And I think we have to be aware and understand that systemic racism, meaning that racism that is baked into so many of our systems, was on display not just in January 6th, but it's on display every day when people don't have access to care. Was our healthcare system built in a way that seems to perpetuate racism? I think so. That perpetuates inequities, that perpetuate disproportionate problems where African Americans and people of color are more disproportionately impacted by so many diseases. Systemic racism is baked into so many of our systems, and it's certainly baked into our healthcare system as well. But the electoral system, next week is an election, and the outcomes of these elections and others may help reinforce whether we are living in a world where systemic racism will continue, or whether we're going to live in a world where change will continually move forward to make us a more equal and more equitable society. Next week's election is important. Yesterday, I talked to a healthcare provider where I was in an appointment with a healthcare provider, and I said to this young African American man, "Are you voting next week?" And his response was, "There's an election next week. We have a big responsibility before it's too late to make sure that our people get out to vote, because what the outcome of this election might be could determine our future, and not only in terms of who's in charge, but how our healthcare systems may exist for the future. The Affordable Care Act is on the line. Social Security, Medicare are on the line. We need the right people to guide us at the state and national level. Now, our judiciary has also been involved in issues that continue to impact the HIV epidemic. And the Dobbs decision, which overturned Roe versus Wade, is Exhibit A, as we lawyers say, and I'm a lawyer, so I love reading these decisions. And I read this decision very carefully. The Dobbs decision that overturned Roe versus Wade included these words from Clarence Thomas in his concurring decision, that in future cases, we should reconsider all of this court's substantive due process precedents, including Griswold, which affirmed consensual contraception, Lawrence, which affirmed the right of privacy for engaging even in sodomy, and Obergefell, which confirmed that the Constitution afforded same-sex couple the equal right to marriage. Now, in the news, we often stop right there. That's all you ever hear. But just a few lines later, Clarence Thomas said this: "We, the court, have a duty to correct the erroneous error established by these precedents." Now, I want to be very clear. Same-sex marriage would not exist had it not been for HIV/AIDS. Because for people like me who lost a partner at the beginning of this epidemic, if I could sit on the front row pew in church to bury my partner, why couldn't I stand in front of the altar and marry my partner? Same-sex marriage is because of the social change that you all and we all have experienced over these last 40 years of understanding that love is love and no one should be denied the opportunity to be married. And that includes Clarence Thomas, who's married to his wife, and that's because of the loving decision. But let's go on. Just 6 weeks ago, the United States District Court for the Northern District of Texas issued a ruling regarding the Religious Freedom Restoration Act and its impact on the Affordable Care Act. A group of private employers sued Mr. Becerra, who's Secretary Becerra of the Secretary of the Department of Health and Human Services, with regard to the Affordable Care Act's provisions that mandate that certain prevention services like PrEP, or pre-exposure prophylaxis, which can prevent a transmission of HIV, that certain prevention services like PrEP no longer be offered by that employer because it offended their religious consciousness, because in their opinion, PrEP promoted sex outside of marriage and sex between same-sex partners. Well, the district court said, yeah, we agree, which was quite a shock. So it concluded that PrEP should not be required, but it went beyond that. It said that the Prevention Services Task Force, which was created under the Affordable Care Act and makes the decisions as to what insurance companies should be required to pay for prevention services, said that the Prevention Services Task Force was created in an unconstitutional way because it did not have the full authority of Congress to have the delegation of the authority that the executive branch has given to it through the Affordable Care Act. It's quite a shock that a court has determined that the entire Prevention Services Task Force might be unconstitutional. So we've got a lot to deal with right now because that case is on appeal, and it's appeal all the way up to the Supreme Court, where the Supreme Court is making decisions like this could be quite shocking. So let's make sure we are aware of the judicial environment that we are living in that can have an impact on HIV/AIDS. And there are states like this map all across the country that either through litigation or legislation have similar religious freedom restoration acts. And take a look at that map, because that map is exactly the map that I want to talk about with regard to the variety of issues that are impacting HIV from all across this country. Well, let's start with the broader issues. Who actually has HIV and where do they live? Of the 1.2 million people living with HIV, nearly half are concentrated primarily in the Southeast United States, where Tuskegee and other historic Black colleges are primarily located. Take note that according to the CDC, there's an estimate that half of all Black gay men and a quarter of all Latino gay men are projected to acquire HIV during their lifetime. And those people are located with the Latinx community and in communities, particularly in the West, but for African Americans, particularly in the Southeast. This map will be continually familiar as we talk more about the epidemic of HIV. 40%, the top map, of all people living with HIV are African American, and yet African Americans make up only 12% of the population. And the largest percentage of new HIV transmissions are, of course, among African Americans. And as you can see, they are largely in the South. So we have a very important problem that we have to address. Not only the epidemiology of HIV, but the political environment in which primarily African American people live who are living with HIV or highly vulnerable to HIV. Meaning, if you're highly vulnerable, you are that statistic that is constantly being increased, that is being hit year after year with new transmissions, those 35,000 new transmissions every year. This problem must be addressed from a moral and political perspective, because if we are not clear that politics and morality impact HIV, then we cannot end this epidemic. Well, let's go on. The challenge of having access to healthcare can be the challenge that will prevent you from ever achieving a viral suppression or an undetectable viral load. And yet that's the gold standard for someone like me who's living with HIV, so that the virus is not replicating and developing, and I'm not going to be developing AIDS or die. But look at the places in this country where Medicaid has not been expanded by state legislatures to make it possible for people who do not have dependent children to be able to have access to the government's insurance program known as Medicaid, which is for otherwise low-income people. If you are not able to get Medicaid and you are a low-income person who does not have children, and you know who those people are, let's talk gay men, let's talk transgender people, and let's talk a lot of Black women who may not be otherwise married or have children of their own. We're talking about our people who do not have access to this important health insurance program. And look at the states that continually refuse to expand Medicaid. Doesn't this look familiar with regard to where HIV is and where Black people with HIV reside? But not only that, these same states are the same states that are retarding the right to have access to abortion. And so the sexual health of our women must be addressed as well, because, for example, Planned Parenthood is a huge provider of reproductive health services, and reproductive/sexual health services include services with regard to PrEP that prevents HIV, and if you have HIV, to medications so that you can't pass HIV on to anyone else and so that you can live a long and healthy life. So if we reduce access to sexual and reproductive health services for women, we are increasing the risk of HIV for Black women particularly, and especially Black women all across the South. We have a big political and moral problem. And that problem is exacerbated by criminal laws at state levels that criminalize the transmission of HIV. Now, how can you criminalize HIV when we know from the science that if you are virally suppressed, you can't transmit HIV? And yet these antiquated state laws, many of which go back nearly 40 years to the beginning of the epidemic, are based on things like spitting and biting, which science now tells us that never were modes of transmission. And let me be very clear. These laws are continually being applied, and the people who are being arrested and put in jail are largely African-American men. So these criminal laws are part of the political and judicial and now criminal backdrop that continually impact how we address HIV, and whether or not the stigma of HIV continues, where laws like this reinforce that HIV is a problem when in fact HIV is really just a health condition. So I want to add one last piece, and that is the political backdrop around the LGBTQ community. You know, since the Supreme Court made its decision creating marriage equality, we all kind of assume, well, isn't it over? No, it's not over in terms of the LGBT community, because as you can see from these two maps, and boy, do these maps continue to start to look very familiar, there are still 29 states that have not passed their own legislation to protect the LGBT community from job discrimination, from housing discrimination, from public accommodations discrimination. So we still have a big problem. In fact, I've heard many people say you can get married on Sunday and then you can be fired on Monday in 29 states. And those 29 states are the same states that have not expanded Medicaid, that are retarding the rights of women to have access to reproductive health services, and on and on. And the same states, of course, that criminalize HIV. So this backdrop is where we are. And I think this is why we have to connect the moral with the political, because we can't end HIV in this country without addressing both. So what do we do? Well, at AIDS United, we've been looking very carefully at our efforts to address what is needed for ending this epidemic. And at AIDS United, we've concluded that we need to be focused very much on health equity, particularly racial health equity, LGBTQ health equity, and regional health equity by looking carefully at what we need to be doing in the South, especially with Southern legislatures. So our advocacy is about legislation at the federal and state level. Our advocacy is about appropriations to make sure we have the funds through federal projects and through state programs to help in this epidemic. And policies, including policies at places like CMS, the Centers for Medicare and Medicaid. Are they truly prepared for the HIV community? So let's look a little deeper at what we mean by health equity and what our priorities are and what our strategies are with regard to advocacy. As we focus at Age United on building health equity for the HIV community, we have to focus on Black men, whether they are Black cisgender heterosexual men or Black gay men, Black women, who are continually the largest percentage of women who are HIV positive, the Latinx community, and yes, we need to think about Puerto Rico because Puerto Rico has a burgeoning HIV problem. For the LGBT community, focusing on men who have sex with men, not the word gay, because there may be men, particularly some who have been through the incarceration system, who may have had sex with men, but who may not ever think of themselves as gay. We need to be aware of both. And the transgender community, whether it's transgender men or transgender women, nearly 60% of Black transgender women are already HIV positive. And our LGBTQ youth, those who are under 24, those are the ones who are substantially impacted by sexually transmitted diseases. And we need to be aware that our youth do not fully understand that they may be putting themselves at risk for HIV. And of course, the South. And we'll talk in just a few minutes about the federal ending the HIV epidemic and its jurisdictions, which focus primarily on the states in the South. So we cannot achieve health equity for the HIV population unless we work to achieve it through a racial lens, through an LGBTQ lens, and also through a geographic lens. And what is our advocacy doing? Well, through our advocacy at Age United, we are focused on the criminalization issues in those 32 states that still have these antiquated criminal laws. We focus our advocacy on expanding Medicaid. And in our efforts, we are working with Congress to increase the incentives that might be offered to states to actually finally pass Medicaid expansion. And we work with Congress on the importance of SSPs, which stands for Syringe Service Programs. Remember that picture from that at the beginning of my presentation of that young man who was injecting drugs? Syringe service programs are critical to provide access to health services as well as to clean needles. It is a shock that after 40 years, with every year 10% of new infections happening in the syringe service community, it is a shock that the federal government still does not let $1 of federal funds be used to actually buy clean syringes that can be exchanged in syringe service programs. Breaking down that legislation and building up the role of SSPs as places where the opioid community, the injecting drug using community can actually get to health services is important. And at the federal level, the Equality Act with regard to LGBTQ equality and even the Marriage Defense Act, those efforts to assure broader equality for the LGBT community are part of our agenda. Now, appropriations. We cannot do this work if the government continues to have flat funding for HIV. So we advocate to build the bipartisan coalition of Republicans and Democrats who are willing to support increases year after year in the federal budget. We didn't have those increases during the last 4 years of the prior president, but we have a president now who understands how important it is to actually bring the resources necessary for prevention services that are created through the Centers for Disease Control and Prevention, for treatment and care services that are provided through the Ryan White program run by the Health Resources and Services Administration, for housing, the housing opportunities for people living with HIV program that's run through HUD. And shockingly, 40% of people living with HIV may at some point in their life find themselves to be housing insecure. And appropriations for sexually transmitted infections, because the intersection, as we discussed earlier, with regard to STIs is really important, including hepatitis, and a new program to ensure that more people have access to PrEP. PrEP is not well understood. PrEP is not being well accessed by anyone in this country, but it is clear that of the 1.2 million people who should be on PrEP, now let me make sure I make this very clear. There are 1.2 million people living with HIV in this country, and the CDC informs us there are another 1.2 million who are highly vulnerable to HIV. Of those 1.2 million, barely 250,000 are currently taking PrEP, and most of those are white gay men. We have a big problem with regard to PrEP access, and that is part of our advocacy agenda. And then our policy efforts with regard to HIV and aging. 50% of us are already 50 years old or older. How do we make sure that senior citizens, senior centers in your communities are ready for the HIV population? How do we make sure that Medicare is ready for paying for the medications that we will need? My dad was in assisted living. I can see the cart coming down the hall with his medications. Are assisted living and long-term care facilities really ready for an aging HIV population? Let's think about that. The 340B program, which particularly helps clinical services through their reimbursement structure, have rebates that can help pay for unreimbursed care for people who are living with and vulnerable to HIV, unreimbursed care for things like food assistance, access to PrEP, access to babysitting and transportation. Those are important, and the 340B program provides those resources. And now our policy on monkeypox. My AIDS United and our partners just yesterday issued a major statement that the federal government should be funding at the billion-dollar level our effort to stop the monkeypox epidemic before it gets worse. So our advocacy over the years has been successful. Through our advocacy, we advocated that it was time for the United States to have its own national HIV/AIDS strategy. And after 40 years of advocacy, that was done by President Obama. And that national HIV strategy was recently updated by President Biden. It has this beautiful vision for where our country should be. And it has these 4 goals on the far right for how we can end the HIV epidemic. And for each of those 4 goals, there are strategies and indicators for how we get to the end of the epidemic. We are very proud of our advocacy, and we are especially proud that after all of our years of advocacy, it was President Obama who put this in place, and it is President Biden who has picked it up and taken it to the next level. One of the aspects of our advocacy within just the last year or two was that the national strategy really should, if we're really going to address the moral issues related to HIV, we need to address quality of life issues for people living with HIV. And within just the last 2 months, the Office of National AIDS Policy at the White House has released these new quality of life indicators to be incorporated into our national HIV/AIDS strategy. And look at what these indicators mean with regard to morality. The bottom left, decrease by 50% the proportion of people living with HIV who ever report being hungry. Upper right. We decrease the proportion of people who report being out of work. And in the far right bottom, decrease by 50% the proportion of people who report that they are HIV, but also unstably housed. Those issues are moral issues for our people, but they are deeply rooted in the political system and the systemic racism system, where people are hungry, people are out of work, people are unstably housed year after year, and the HIV community sadly reflects that really, I think, unfortunate moral dilemma for our country. Now, within the Department of Human Services, they have their own strategy that is a part of the National HIV/AIDS strategy. The Department of Human Services includes the CDC, the Health Resources and Services Administration, or HRSA, and NIH, where we know Dr. Fauci is, the National Institutes of Health, as well as SAMHSA, the Substance Abuse and Mental Health Services Association. That department and those agencies have this plan for ending the epidemic by 2030. And their plan was substantially based on the advocacy that AIDS United and our partners did by urging the government to put a deadline in place by which we could end this epidemic. And through this effort, the Ending the HIV Epidemic Plan in America, HHS is focusing on these 57 jurisdictions where if we can end the epidemic there, we can end the epidemic in the United States. And look at where those jurisdictions are on this map. Substantially in the South, 48 counties and 7 primarily southern states. But let's talk about what that means. So our advocacy has been successful in creating a national HIV/AIDS strategy. Our advocacy has been successful in urging HHS to develop its End the Epidemic plan, but our advocacy is not over. We still have more work to do to achieve true health equity based on a racial lens, an LGBTQ lens, and a Southern strategy lens. And so that's where AIDS United continues to do our work. And next year will be the 30th anniversary of our premier program. It's called AIDS Watch. For 30 years, we've brought grassroots advocates directly to Congress to tell their stories to members of Congress of what we need to end this epidemic. Over the course of our efforts through AIDS Watch, we bring those grassroots advocates together for one day of great training to understand the issues. And then the next day, we have those meetings with Congress. In 2019, the last year that we did it in person, prior to the pandemic, 650 advocates from 40 states came, and in one day, they had 250 meetings with Congress. At our recent celebration, Nancy Pelosi praised AIDS Watch because she knows how important it is for her colleagues to hear directly from the grassroots. At AIDS Watch, during these last 2 years, when we've been virtual, we've heard from Harold Phillips. Harold Phillips, whose picture is at the bottom right. Harold is now the director of the Office of National AIDS Policy at the White House. He's the one who led the charge to extend the national HIV/AIDS strategy, and he led the charge to create those quality of life indicators. Harold is a Black gay man living with HIV. And at our spring issue of AIDS Watch, which was virtual this past spring, we had Dr. Rachel Levine. Rachel is the first transgender woman to ever be approved by Congress for a federal position. She is the Assistant Secretary of Health. There's only one Assistant Secretary of Health, and all of the Office of Minority Health, the Office of Women's Health, the Office of HIV and Infectious Disease Policy at HHS, and all the prevention and all of the Public Health Service Corps reports to Dr. Rachel Levine. She gave a beautiful keynote at AIDS Watch for our 29th anniversary, but I'm inviting all of you to participate in the 30th anniversary, which will be live and in person on March 26th to 28th in Washington, and we will take our message directly to the new members of Congress. And AIDS United has launched our Racial Justice Index. After the murder of George Floyd, our Public Policy Council said, well, how reflective are we, the HIV sector, of the racial communities that we serve? And so through 2 years of conversation, the Public Policy Council has decided that all of our members would go through a reflective process to assess just how reflective our organizations are in the HIV sector to the communities we serve. It will be a scorecard that will look at their boards, their executive staff, and their constituents and their clients. Is there a mix match? You know, there's an awful lot of what's called snow capping, where at the top of an organization, the person who's leading the organization serving people living with HIV does not match the community that is actually being served. Let's take a look at that from a racial justice lens, and AIDS United will be able to help organizations to perhaps move forward and transform so that they can be more reflective. We launched this with a pilot group of PPC members over the summer, and this month we've announced that we're launching it with the entire sector, and it may go beyond just our Public Policy Council to organizations like pharmaceutical companies and pharmacies and others to see how reflective they are of the HIV community they serve. But what can you do? Well, as I close for my comments, I want to be very clear that you all have a role. The Center for Bioethics has a role. Take part in legislative activities. Join us in legislative days where we can, as a community, go and speak directly to our legislatures and our legislators, be it at the state level or at the federal level. Action alerts from coalitions like from AIDS United go out all the time, where we send action alerts. Call your congressman, send a message, email them, or sign on letters. These letters are actually read by the staff of our legislators, and they can be impactful because they show that the constituencies of those who elected them are concerned about these issues. And don't be afraid to actually meet with elected officials, whether it's the mayor, the county commissioner, because we know that there are governors all across the South particularly who are ignoring HIV and do not have HIV on their own legislative agenda for their state houses. This must continue to change, and that is exactly what you can do to help. Take action through legislative action. But Tuskegee, the Center for Bioethics, has a unique role that can be played with the media. Identify for the media what stories need to be told with regard to the issues you're addressing, whether it's HIV or COVID or violence. The media is looking for opportunities to promote great stories, and we have great stories to tell about what we're doing and great stories to tell about what we need to end this epidemic. And you can take action by attending those town hall meetings. How many times do we see town hall meetings with an elected official or with a candidate being aired on television? We have the opportunity to actually participate in those. Don't be afraid. And don't be afraid, if you're a doctor, to actually wear your white coat when you go to those meetings and talk about HIV/AIDS. And don't be afraid to offer public testimony, written testimony from from people who understand public health can be hugely impactful as our legislatures look at how to craft legislation and also to understand what the public opinion really is about the issues that they're facing. So lastly, protests. We know that our community, the African American community, has had so many advances because of nonviolent protests. Protests definitely state for the public and for our people what we need and what we want. And electoral organizing, the opportunity to participate not only by encouraging people to vote, but involving ourselves in PACs and 501c4s that bring resources to the right candidates is a unique way that we can help influence who gets elected and who actually serves as leaders for our people. Well, I want to close by saying this. I am clear that we are not the minority. People who are concerned about HIV cross-cut many different constituencies. The Black Lives Matter movement, the women's reproductive justice movement, the LGBTQ movement, the immigration movement, those all cross-cut the core values that support our people. And I've added to this slide the climate change movement. Why did I add it? Because our young adults who are concerned about climate change understand the importance of science and the science and the biomedical opportunities that can transform people living with HIV, that can stop people from ever having HIV. That science is clear, as is the science of climate change. We and our allies are the majority. And my last word for all of us is this: let's act like it. Thank you all so much. David, Ruben, Alonzo, back to you.
Thank you, Mr. Milan, for taking the time and presenting with us today. We're going to get into our Q&A portion. Our first question: has any work been done with the homeless population as to HIV/AIDS?
Absolutely. The National HIV and Housing Coalition works in partnership with AIDS United. And we've been working very hard with Congress to increase the appropriations for the housing opportunities for people with HIV. And for too long, HOPWA funds were at a flat level. We've been able to get some modest increase in the last year, but as we move forward, we know that the percentage of people who may be unstably housed because of the economy will continue, and that will certainly impact the HIV community. So yes, we are working in coalition with housing advocates to increase federal appropriations to provide housing opportunities for people living with HIV.
Thank you. Next, we have a comment from Suchita Patel. I'm sorry if I'm mispronouncing that name. Great presentation, content, and speaker. Thank you for all your comprehensive work.
Well, thank you for inviting me. It's a great pleasure to be here.
Next, we have from Tahira Hoskins. Mr. Milan, your presentation has been extremely informative. I would like to mention that just as you commented on the young person who was unaware of the upcoming election, the same issue of lack of awareness stands true regarding the topics you covered regarding the HIV epidemic. Do you have a referral that could serve as a resource to help educate and promote awareness at the community level?
I certainly, AIDS United, our website, AgeUnited.org, provides some resources. But I also think it's important for people not to be afraid to go to their own health departments, because health departments all across this country are getting federal money for exactly this purpose, to provide resources and education. And I think in every one of our communities, there's a lead HIV/AIDS organization. Many of those are grantees of AIDS United. Just reach out to one of those organizations as well. And in some instances, those organizations include Planned Parenthood. and they can provide additional resources that can be used right there at the community level.
Thank you so much, Alonzi. Thank you so much, Mr. Milan. Of course, I was supposed to be responding, and Alonzi was supposed to introduce me, but everybody knows who I am. So then let's. I just want to continue this conversation because Daniel Dawes has written a book called The Political Determinants of Health. Dana Boyd Matthews has written a book called Just Health, justice, essentially justice and health. You spoke brilliantly about the moral determinants of health, particularly HIV. But I didn't hear what I didn't hear much about, and I asked Dr. Riggins Earl, he's our resident theologian at Theological Emphasis, to come on screen. I would like for us to have some conversation because you mentioned how the immigration situation, of poverty, of all of this. By the way, these are the same kinds of points emphasized by Dr. Mays yesterday when she called for a Belmont 2, that we need to promote the notion of social justice to get to particular issues. So the question I have, I want you to reflect on, is the thing that I didn't hear much about is the spiritual determinants of health. Central to public health is the social determinants of health. Oh, by the way, I want to thank Sister Jo Valentine. She's our amazing colleague liaison with the CDC, and she's on with us right now. I also wanted to thank Lachlan Fall. As we mentioned earlier, he's on, by the way. I'm surprised he didn't ask a question yet. He usually leads in the questions. He, along with Kathleen, Dr. Kathleen McDuffie, Dr. Riggins Earl, this lady Head, who is the president of the Voices for Our Father Legacy Foundation. We started this process 9 months ago, trying to put together this conversation. So the one thing I wanted to just kind of speak to is this notion, the thing that cuts across all of that is also the spiritual determinants of health or the religious determinants of health. Please tell me, has there been any shift in the last 20, 30 years, 40 years with the stigma of HIV and AIDS? Are churches still willing to march against gays and lesbians and HIV and AIDS and further creating a distraction for your work? Are churches your nemesis? Not your nemesis personally, but a nemesis to the advocacy that you're trying to promote. Tell us something about that and how we can. Dr. Warren is an ordained elder, ordained minister. Dr. Riggins Earl is, of course, a professor at ITC, Interdenominational Theological Center. I'm an ordained pastor. Please help us to understand how our role and the spiritual and religious role can help what you're trying to accomplish.
Dr. Rubin, Dr. Warren, would you like to respond first?
You're on mute, Dr. Warren.
Yeah. Let me respond because it's a question that has to be answered. I think the fundamental issue is we've had a role in all other movements of social justice, the faith community, particularly the Black faith community. And this is one that we cannot ignore. We were late coming, but I think we're in it as we should be, and we cannot be forgiven for not participating as we should. The faith community has provided leadership for the Black community and the nation, if not the world. So I think we have to demand of our faith leaders to do the things they've been doing in other kind of movements.
Excuse me a second, but Dr. Warren, and this goes to any of you. Once there's a conflation between HIV is known as a gay disease, right, and now transgender disease, and the church is staunchly against marriages And Mr. Milan, condolences, but you said that very brilliantly about, I forgot how you said it, but sitting in, you're allowed to sit on the pew at the funeral. You can say it better than me, but can't stand at the altar. The two have been married together so tightly that it seems that to reject one is also to reject the other. And Dr. Warren, what you said is actually brilliant. That the church, not just the church, but the spiritual community, the religious community, has been at the forefront of legislation, of protests, and so on, except for this. And the question then is, how can we make it happen?
Let me respond a little further. To say the church assumes that it's all one entity, but there are various components within the Black church I can speak to who are very active in the HIV and AIDS community. I think we have to find that congregation and that faith leader, and then follow her or his leadership. I think it's there, but the notion of this is one homologous community, I think is a false notion. There are active participants, and I know some of them, and more of them need to be recognized and engaged.
I would totally agree. I think that many of our churches have a different pathway into addressing HIV by addressing it as a health issue among other health issues that their congregations need to be aware of. I've understood that when we combine HIV screening with other health screenings, including diabetes and prostate cancer, we say, take care of your whole self, and your sexual health is part of it. Go get tested. And that pathway helps break down a lot of the stigma that it's a problem that all of us should be aware of, because it basically exposes that sexual health has never been a comfortable conversation for congregations. Sexual health, particularly among people who are not married and among our youth, has never been a comfortable conversation. And then all of a sudden we discover that we've got a 16 or 17-year-old member of the congregation who's pregnant. And that conversation then clamps down again. Sexual health issues should be part of our broader community health conversations, and that's an easy road to discuss HIV. The issues about sexuality are ones that I think every congregation and every minister and every member of a congregation has to continue to address from where they are today. We've now had 40 years of HIV, and frankly, the decision, the Obergefell decision by the Supreme Court, is a beautiful one, because it basically says love is love is love. And in our own families, we see that. We all have someone, or we know someone, or we are connected or related to someone who may be in a same-sex relationship. And frankly, how we treat those people are examples of our leadership. And it's actually time for, in terms of HIV stigma, for people to stop being silent and say, you know what? I love someone who is. I love someone who has HIV. That's how the stigma of HIV starts to break down.
Thank you, Mr. Milan. One other clarification I would like you to make, and then I want to get Dr. Riggins Earl in on this to reflect on what was just being said, and then Alonzo Bryant will then ask the next question in the queue. So the one thing I want for you to reflect on is can you say something more on when you're speaking with Clarence Thomas and the same point that you're making? Can you reiterate or clarify what you were saying about Clarence Thomas and his position on what you just said?
Well, Clarence Thomas in the Dobbs decision basically sent up a flare that he was ready to overturn some important precedents. Notice that he did not include the Loving decision, which confirmed that people have an equal right to marriage with someone from a different race. Notice he didn't say that. But his flair in the Dobbs decision around Lawrence and Griswold and Obergefell, I think, is a bellwether for us that this conservative court is watching where it can take back or eliminate rights that for the last 2 generations have been important for all of us.
Alonzi, please ask the question.
Yes, so from Lachlan Foro, I'm sorry for mispronouncing that name. First off, they have a comment. I think the fundamental issue for the moral determinants of health is whether or not we Americans truly believe that all men/Americans are created equal, with equal rights to life, liberty, and the pursuit of happiness, or the Pledge of Allegiance's commitment to liberty and justice for all. Question: how can the National Center for Bioethics at Tuskegee contribute to translating these lofty words into deeply patriotic instance on what those words require we do for and with every American with or at risk for HIV/AIDS?
Well, I thank Lachlan for that question. Lachlan is a classmate of mine from college, and he helped make it possible for me to be here today. So thank you for that question, Lachlan. I think the National Center for Bioethics and Healthcare has a leadership role for legislators and for government leaders, but it also has a leadership role for the community. And those two are not different. The strategies may be different as to what we do to inspire the community to rise up to do what is needed for changing the trajectory of HIV and COVID and maternal and child health, but also the role that it plays to change the trajectory of what our elected and legislative leaders might be doing. I think the center has a very unique role in both arenas.
Dr. Earl, would you like to chime in?
Thank you, Dr. Hodge. Mr. Milan, thank you so much for your provocative presentation, informative. Excuse me. I want to get to the issue, and Brother Lachlan raised it for us in terms of, when we talk about morals, we have to talk about moral discourse. And we also have to talk about myth, mythic language, and how those myths, or the language of a myth, defines in certain periods and generations, defines who's good, who's bad, who's right, who's wrong. And I think if there's going to be a bioethics center that helps us Black people, we have to really get at that, especially in the South. Because let me give a good illustration, I think, of what I'm struggling with is, and of course, Dr. Warren has heard me talk like this ever since I've been associated with the center. Because I just believe it, and I believe that you cannot talk to people about this unless they understand how this language has shaped them. The former president did something to us that we have struggled, and probably we don't even struggle with in our Black colleges and universities. And that is, and when I say struggle with it, I mean really try to get at the root of it. That is, he said to America, we're going to make America great again. Well, the issue, this is a language something. Here's a man who's filthy rich, who picks up a language or part of a discourse that hundreds of thousands and millions of people responded to, as though there was a time when America was perfectly moral. And that becomes you have to raise the question. Now, I know that in bioethics centers, I've heard blacks say to me, well, you're not, ethics is not, you're not being, you're really not dealing with the problem. You're talking. But hell, we talk every day, and people talk myths every day. And they talk out of myths that are as big as America. We hold these truths to be self-evident. That's mythic discourse. And for people to not understand that, whether you're in college, at Harvard, or whether you're at Tuskegee, to not understand that is to not understand that there's something in our subconscious that makes us make decisions about who's clean, who's unclean, who's right, who's wrong. Now, we can call it religion, or notice Trump did not call it religion. He called it the language of governance. He referred to it as the way America has been. And I don't think in a Black culture, you cannot talk about having a bioethics center in America without dealing with those myths, without talking about how do we deconstruct this notion of who is the gay person, whether in religion, and it wasn't just religion, it was also politicians who, especially in the South, and in not just the South, but the whole nation, who has seen gay people as being the aberration, they are far from being human. And we are not willing to talk about it, to struggle with it as a moral issue, because our language has been perverted. Not only did we do it with gays, but with Blacks, with women. They are not equal to men. So I heard somebody who was a powerful person in this country in the medical field say to me, well, ethical discussions are a waste of time. Moral discussions are a waste of time. Well, you need to get out of the human community, because the human community cannot exist without moral discourse. And people, and you raise it to a political level in Washington, it's raised to a political level. Moral discourse is decided by political discourse. And I hope for the young people that you will hear this and hear what I'm struggling with. Not to hear, well, is he right or wrong, but to hear that I'm struggling with something that America, every nation has to struggle with: moral discourse and self-identity. Riggins Earl, as I was told when I was a little kid coming up in school, they would call us ink spots, the little dark ones like myself, ink spots. And they would say, ink spot, you're wrong. You are wrong because you are too dark. That was a moral evaluation from my peers. And if my teacher chimed in and said, get your hand down, you're too black, all that shaped my identity, that I would have to someday in my struggle try to deconstruct. The civil rights movement became a place that became a school for me of protest and all of that, of trying to deconstruct that. And I'll quit this when I say this, I don't know whether there's a Black church anymore, because if so, it's a very tiny entity. Most Black leaders in the churches are sleeping in the bed with white evangelicals. And these are the people who are making decisions and got lobbying groups in Washington dealing with policy. They are the white evangelicals are the people who have controlled the moral discourse, oftentimes, too often, for Black America as well. And those Black preachers that they controlled vote against Black women for women, period, for positions. They also vote against anything that has to do with gays, positive, that has to do with the LQB community. I didn't get it right, but you all correct me there, please. But the point, yeah, the point that I'm making is we have to hear this, because what's going on in Washington now with the lobbyists, and I try to stay in touch with it weekly, but with students that I've taught who are in the lobbying industry, that if we don't keep up with this, what we're doing down at Tuskegee is a joke. Whether it's a joke in the classroom or in the bioethics center. Now, I have a way of making people mad and upset, and they curse at me. But it's a reality that we have got to face. I listen to these conservative preachers preach, and they sound, if you could paint white on their faces, these white conservative leaders, you would say, my God, he must have been the child of so-and-so. I've been working in South Carolina doing a major project, and it is mind-boggling to see how my people, and I know you'll say, well, you got the same thing in Georgia, but I'm talking about the people in the legislature who are senators, and they are Black, and it's almost as though they are marching with an invisible sign, I hate my people.
Thank you so much, Dr. Earl. So you presented to us actually the question I'm going to post to Mr. Milan, and I think you just covered that. Because the question I was about to pose, the final question, and for you to have the final word, Mr. Milan, is this something what Dr. Earl just said? What are the distractions to the trajectory of eliminating HIV and AIDS? What are the distractions? You know, there's anytime we have a conversation about this thing or the other, it's almost like a feud between energies or between purposes. Miss Carmen Thornton, she said something yesterday that was very, very important. She said, well, speaking about, she's a descendant family member. Her grandfather was in the so-called syphilis study. So what she said was that the competition between what happened in a 40-year-long non-therapeutic study and the evil there as being in competition with say what happened in the Holocaust, or what happened in Guatemala or different places, is that we can't focus on one and they put them to compete, like which one was worse. And so as we make this fight, so we can stay focused on whatever the issues are, some of those things cross over, as you said, there's a kind of cross-pollination of issues. But then what are the distractions that we need to avoid so we can stay the course to get legislation done?
I think that the Center for Bioethics has a unique opportunity to not only affirm what constitutionally we should be doing to assure equal protection and equal access to healthcare, to human rights, but the higher role of advocating for what is morally right. And the marriage between the Constitution and morally right is a tension that is a political tension. And that political tension, which we are living in right now, can go one way or the other. But we need it to go in the way that affirms who we are and who we as a people want to be. And it is time for us, through HIV especially, to stop looking backwards at what we didn't do and what was said in the past, and start looking at where we are today and where we want to be. We now live in a world after 40 years of HIV where living next door to someone who may be a same-sex couple is not a shock. Recognizing that that person sitting on the bus next to you is a transgender person should not be a shock. And stop looking at it from, oh my God, 40 years ago, 20 years ago, I would never have been able to do that, but you can now. And are we recognizing that that person, I'm that next door neighbor living in a same-sex relationship, and I've lived next door to Republicans for 16 years. Guess what? They invited me to sit at their table at their son's wedding. That's where we want to be tomorrow, and that's where we can be today.
That is a great way to end it. Thank you so much, Mr. Milan. One of my Black theology heroes, Dr. J.D. Otis Roberts, professor at Eastern and then at Duke University. He passed away a few weeks ago in his 90s. He's also the father of Zane, the author. J.D. Otis Roberts said in his book Black Theology and Reconciliation, he said, the goal is to be more fully human. And I always, that statement that stayed with me. That is so consistent with what you're saying. Thank you so much, Mr. Milan. You have given us so much on the table today. So much for us to meet out as we go forward to the National Center for Bioethics and Research in Healthcare in making sure we impact these things that are so very, very important. And following up from what Dr. Vicky May said yesterday in terms of Belmont 2, this thing is just so consistent with me. Dr. Warren, do you want to say anything else before we end this session and begin the next session?
I just want to say thank you and thank you.
Amen. We want to say thank you to Mr. Alonzi Bryant, our student host, and for performing so well, Mr. Bryant. We thank you. We appreciate you.